Good morning, good afternoon, wherever you're joining us from. Welcome to our Mobilize You Wellness webinar series. My name is Michael Johnny, along with Krista Jensen. We make up the staff complement of York's Knowledge Mobilization Unit, which is part of Innovation York. We are pleased to host today's webinar. While we're all working remote, I want to acknowledge the territory that I am on and that York University resides. During these unique and challenging times, I'm especially privileged to work and play on the ancestral lands of the Mississaugas of the Credit Nation. It is lands that are also shared by the Haudenosaunee Confederacy, the Huron-Wendat, and other nations. These lands are protected by the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for this region. We are further privileged to have two speakers today, leaders in this field, who will share their research and experience on this topic. Dr. Nazilla Khanlou and Dr. Attia Kahn. A few housekeeping items before I pass things over to them. We are going to end at 1 p.m. Eastern promptly today. That means it is possible that not all of you may have an opportunity to ask your questions. This is being recorded. We'll make it available on the Knowledge Mobilization website, but also pass it over to our presenters to share as well. During the presentation, everybody is going to be, well, except for the speakers, are going to be muted. We'll open it up at the time where we can open it up for questions. There's a windstorm happening in Southern Ontario here, so in the event that there's any issues with connectivity, please excuse that. It's a little beyond our control. And with that, I give my thanks to our speakers and pass things over to them to get things started.
Thank you very much, Michael. And as we are waiting for Krista to screen share our PowerPoint, on behalf of myself and Attia Kahn, we thank the Knowledge Mobilization Unit for the opportunity to present. And we thank both Michael Johnny and Krista Jensen. And we thank you, the audience, for making time from your busy schedule to join us today. Next slide, please. The outline that we'll be following is as follows. So I'll share with you a little bit about the background, my journey into this topic. And we will talk about what the issue is, what we know about the issue in terms of mental health impacts of the pandemic on service providers. We'll specifically focus on healthcare workers. Both Attia and I are from health backgrounds. So my background is nursing and Attia's background is internal medicine. And over the course of our careers, we've gone on and attained PhDs. So then we'll share with you what we know about what's being done. And finally, we will have some ideas around how to address the issue. Throughout this webinar, we have in 3 places put some questions that we'd like to hear from you about. And you can start typing up your questions into the your responses to the chat box if you wish, or wait to the end. We have quite a bit of time in terms of engaging in dialogue towards the end. But there are a few opportunities for us to pose questions to you, the audience. Next slide, please. So I'd like to share with you a bit about my journey into this topic. We were just before going live, we were commenting on how it's been a year now since we are, as York members, are working from home. And I remember, a year ago, almost a year ago, as the first wave of the pandemic was being discussed about and preparing to go through lockdown, I was thinking, and I teach nursing students. I have colleagues who are nurses. I have family members who are in the health field, just not knowing what to do. And this is a tweet that I tweeted March the 19th. If you permit me, I'll read it briefly. Then one day our world changed in the speed of a breath as it took breath away. We were told to stay put, to wait it out, to be brave. Bravest were those in uniform of the healthcare kind, nurses and doctors and staff. With their hearts and knowledge, they stood to fight it selfless. Next slide, please. And as the days went on, the weeks went on, you know, very early on, it became obvious that this was going to have, both the pandemic and the lockdown was going to have mental health impacts. And I wrote an editorial towards the end of March. And this is just a bit of the editorial. I'm back then, and I still do, arguing that we really need a public mental health system. So what the pandemic did was it really underscored the importance of a public health system. People started talking again about public health, but we also continue to need, and we still don't have a public mental health system. So just to quote from the article, public mental health promotion and care in Canada, and I would think in most parts of the globe, is not where it can be in 2020. But if we are to take away some lessons learned from the current coronavirus crisis, when rapid societal changes are taking place, we cannot forget our public's mental health. To do so would result in individual suffering, rules not followed, well, community discohesion and citizenship isolation. So this issue still continues on, and I'd say it's compounded. We do have, if you're interested in the reference, we do have the references at the end and throughout the slides, and both this reference and the next slide, please, are open access. So they are free and available for you to look at if you wish. Shortly after, in April, my colleague and I, Brenda Orziati, who is a faculty member here at York University in the School of Nursing, you know, we started hearing from nurses out in the frontline the impacts that back then they were facing and continue to face over time. So again, just a quote from this article of ours. Nurses have demonstrated remarkable resilience and professionalism, while each day the number of identified cases and those who fall increase. But as the pandemic weeks turn into months, perhaps seasons, and we pray not years, the toll on their mental health cannot be ignored. And unfortunately, you know, we are into the second year, and it is turning into more than a year. And the shape of it is changing. And since then, this was in April 2020, issues around mental health for frontline workers have increased. They certainly haven't decreased. Next slide, please. And again, just sharing you my journey in terms of looking at the impacts of COVID-19. I've been a part of two teams. One I was the principal investigator of, and then the other I was the co-investigator of, looking at the pandemic mental health effects. In one study on mental health support for racialized women at risk of gender-based violence, which I led, and then the other one, which I'm a part of, the impact of COVID-19 on the mental health and well-being of caregivers and families living with autism. And these are funded by CIHR. It was a rapid call for knowledge synthesis, which we applied to and were funded. So just sharing with you some of the work that we've been doing and a bit about my own journey. Next slide, please. Now a bit more focus on today's topic in terms of human service professionals. Human service professionals provide a range of services to societies, communities through government and non-profit agencies, and they promote and support the health and well-being of communities, either through providing services or helping people navigate services, etc. They include a range of professions and paraprofessionals, and which can include nurses, physicians, counselors, psychologists, social workers, etc. So that's not an all-conclusive list that I mentioned. And in today's presentation, we'll be focusing on frontline healthcare workers. This doesn't mean that other frontline workers outside the healthcare field haven't been affected, and we recognize appreciate their work, and so it's going to be the focus of our presentation. Next slide, please. Just to give you a heads up, very shortly, there's going to be a whole issue of the Journal of Concurrent Disorders, which focuses on the health of frontline workers during the COVID-19 pandemic. This is a fully open access journal, and there are contributions from Canada and internationally and from across disciplines, as well as the service providers, educators, researchers that have looked at the health impacts of the COVID-19. And I was fortunate to be the guest editor for this issue. We had a call for submissions, and this will be launched very soon. Next slide, please. So let's look at some of the knowledge that we have in terms of the pandemic COVID-19 at the global level. The pandemic has placed unprecedented stress on health systems globally, and there's been a massive increase in workload in the ER departments and intensive care units. ICU been overflowing with patients requiring immediate emergency management, and hundreds of patients, have died throughout this pandemic in different parts of the world. Early on, you'd remember that there was a global shortage of PPEs, and the doctors, nurses, and other healthcare professionals and paraprofessionals were exposed. We're facing challenging work situations. And this is from ICN, the International Council of Nursing, that deaths related to nurses are over 2,200, and that number has obviously increased since the last time this was published. Next slide, please. So in terms of what we know at the national level, workers in the service sector are less likely to be able to work from home. And frontline health workers have been most impacted by the reality of working in a contagious pandemic situation. The infectivity burden is particularly high among healthcare workers, who are estimated to account for 19% of all national cases of people with COVID-19 in Canada. And this is a statistic from mid-August of 2020. Public health departments, as some of you recall, are recruiting retired, non-licensed doctors and nurses to help out, and creating testing centers, call centers, and etc. So next slide, please. In terms of what we know at the local level, Toronto-based ICES, which is formerly known as the Institute for Clinical Evaluative Sciences, data shows that there's a high proportion of positive cases among immigrant healthcare workers, and among women who immigrated as economic caregivers. They've come from different backgrounds, often racialized backgrounds, and nurses are working under the Emergency Measures Act. And we are hearing all the time that there have been increases in mental health care needs in nursing and other professions. Next slide, please. And looking at it from a unique and complex occupational trauma, overstretched staff are experiencing increased psychological distress in the face of increasing and changing workloads. And healthcare workers may also be experiencing high levels of moral distress as a result of having to make very difficult decisions in the work environment in relation to patient care. Post-traumatic stress disorder, PTSD, related to repeated crises is faced in relation to volumes of patients that die and don't make it, despite the aggressive healthcare measure applied to them. There's also been, so in addition to mental and physical exhaustion, there have been experiences of abuse by members of communities who fear healthcare workers may spread the disease when they come back home to their neighborhoods, to their communities. And there have been reports of racism towards healthcare staff who are from Asian backgrounds or with Asian appearance. Next slide, please. So, as Attia and I were talking, we're reflecting on we can't separate the personal and home environment of healthcare workers. Healthcare workers navigate, they go home after a shift, after their clinical context. And so that blurring of boundaries in terms of risk in the work environment and what happens at home. So they've had to confront the reality of the risk to their own health, and while at the same time fearing of bringing the virus home to their family members, and navigating and handling how they might put their children, partners, and others at risk. So this notion of blurring of boundaries between personal and professional service spheres is very much experienced by frontline service providers. Next slide, please. In terms of the community level, healthcare workers are living and working both within the community population epidemic that we're all living in, as well as the frontline realities of their work setting. And so in relation to shared trauma, healthcare workers are sharing both the collective trauma of the community that they live in, as well as the experiences, the particular stressors in their workplace in relation to trauma. So a lot of points raised. Next slide, please. And at this point, before I hand over to Attia for her thoughts, is we'd like you to think about and share with us in the chat box, as well as when we have an opportunity at the end for dialogue, to reflect on what are some of the long-term impacts of the pandemic, as well as short-term. So often the focus, as we are in the pandemic and various waves of it and various lockdowns of it, we're thinking short-term. But if you have also any thoughts on what the long-term effects are, please share with us either in the chat box or when we engage in dialogue. So at this point, next slide, please. I'll hand it over to Attia.
Thank you, Nazilla. That was a very comprehensive way of explaining what healthcare workers are going through. So I'm going to carry on from what has already been discussed. So next slide, please. So as Nazilla just mentioned, that we cannot separate the healthcare workers from the trauma they're experiencing at work and the trauma they're experiencing in their homes, in their community. So, but we also need to look at some other aspects of what the healthcare workers are experiencing. So we cannot separate the elevated risk to COVID-19 from gender and racial ethnic backgrounds. So these people, the healthcare workers, their exposure to COVID-19 is also shaped by the intersection of gender and racialization. In Canada, a large sector of the healthcare force is represented by women. They make up at least 86% of the registered nurses and 40% of the physicians. And we also know a large proportion of the staff that is engaged in these occupations in the residential home facilities, in home care, such as being nurses' aides, orderlies, and even the client service associates, is largely made up of women. So female healthcare workers are not just at the front line in these occupations, they're also at the front line in their homes, as Nazilla just discussed. So they are also the primary caregiver for their children. And they also have the aging parents in their homes and who are experiencing the pandemic. Next slide, please. Race and migrant status is also, it also contributes a lot to what the healthcare professionals are experiencing. So the share of immigrants in the nursing, residential care facilities, and home care occupations has grown much more as compared to other professions over the last 2 decades. So in 1996, 22% of people who were immigrants in these occupations, they were at least 22%. And in 2016, the share by immigrants in these occupations had become 36%. So probably if we were to look at more latest data, and if it's available, it might be even larger. So in all over Canada, if you were to look at these occupations, so 31% of people are immigrant women working in these occupations. And the share of immigrant women is even higher in metropolitan areas such as Vancouver, Toronto, and Calgary, where they make up at least 70% of these positions. These positions are filled by immigrant and vast majority by immigrant women. Reports have also shown that the Black and Filipino workers are more highly represented in these occupations. So 12% of workers were Black and 11% were Filipinos. And if you compare them to other occupations, these two ethnic people of these ethnic backgrounds, they only make up 3% of workers in other professions. We have also been hearing a lot that there are certain groups in the community of specific ethno-racial backgrounds who have a higher rate of being infected by COVID-19, specifically people of Black ethnic background or Asian background. Next slide, please. We also know that there are many barriers that have been identified to an equitable access to mental health care. The mental health care system in Canada is largely fragmented, and the publicly funded mental health care coverage is usually geared towards the tertiary end of care, such as psychiatric services. And private funding is mostly available for those people who have a full-time job, they have health insurance, so they can have access to psychotherapy or even clinical psychology, clinical psychologists. So mental health care services are also mostly concentrated in large cities. So people who are residing in rural or remote areas, they have many challenges accessing care to the mental health services. Next slide, please. So we've talked about what has been, what the healthcare force, people who are working in the healthcare force have been experiencing at the national, global, and local level, as well as in their homes and in their work environment. But we're also wondering what is being done? Has the international community taken any steps? What's going on? So we know that from what reports have shown, the WHO and the International Council of Nurses, and also nursing unions and associations around the world have regularly been sounding alarms on the safety in the workplace and lobbying the governments. The Organization for Economic Cooperation and Development has called for paid sick leaves as a way to respond, as a way to protect the sick workers' income, their health and jobs as they go through the COVID-19 pandemic. Professional specific initiatives are also emerging to help support the mental well-being of frontline health workers and also first responders. In the United Kingdom, institution-based mental health support services have been created for the healthcare workers. Specifically, the staff support centers have been very successful. And staff have also been provided with psychoeducational resources that they can access and help themselves as well. In the United States of America, the National Safety Council, which is America's safety advocate, they have developed recommendations that healthcare and frontline workers can utilize to manage their own mental health. Next slide, please. So what is being done at the national level? Professional specific initiatives have also emerged that help support the mental well-being of frontline workers. The Registered Nurses Association of Ontario, they have been supporting their members online. They created this peer-to-peer Facebook support group that they moderate, so that provides the nurses with some support that they can support their peers and each other. And there have been multiple calls to action by different organizations, by associations, to address the systemic inequities that exist. Specifically, as we mentioned before, there's a group of economic home care workers who are who have been significantly impacted by the COVID-19 pandemic, and they have precarious jobs as well. So we need to address that as well. There have also been increased calls by different unions, by associations, that the Ontario healthcare system needs reforms. Things need to change. They need to be revamped. A whole society approach has also been proposed. What this approach suggests that the concerted effort between the federal, provincial, and territorial government should be, they should work together to limit the spread of COVID-19. Next slide, please. At the local level, what are we doing? Employee and health and safety wellness resources have been created online, and so some of them some of my colleagues as well have been discussing, such as at the Trillium Health Partner Hub. They have made available a number of mental health resources for the staff, and infographics that staff can use and help themselves, specifically because when they're working, when the workload has increased so much and people don't really have so much time. So these resources are available to help them cope with, when they're with the mental health, and also to provide them build resiliency. The Toronto Public Health has started to collect information on people who test positive for COVID-19. So they select socio-demographic characteristics, such as what their indigenous identity is, what their ethno-racial identity is, the household income size, and the household income. This kind of data is being collected after there had been multiple calls by experts that socio-demographic data needs to be collected. Next slide, please. So we have a question. So we will, because we also want to know your opinion about what we just discussed, and you can type out the question in the your responses in the Q&A box at the bottom. So how can we ensure our mental health system is equitable, and that individuals who most need mental health care during the COVID-19 pandemic, and of course in the post-pandemic, in the recovery phase, how can they receive that care? Thank you. Now I'm going to give the mic back to Nazilla, and she's going to carry on from here. Thank you.
Thank you very much, Attia. Next slide, please. So we're moving on towards the last part of our presentation, looking at some ideas in terms of how to address the topic more systematically. Next slide, please. So this is an idea that still thinking through. In the past, I've written about a community, a whole community approach towards child and youth resilience, and thinking about how we can apply similar principles in managing the mental health impacts of the pandemic. If you see on that graph on the slide, a whole community approach can be very much an upstream approach, where the different initiatives, and some of which Attia just talked about, at the various levels work together rather than isolation. So thinking about it in terms of an upstream approach, we need to address the more macro level political and policy supports. and also look at then the interface between the family and the work environment for frontline workers, and finally focus on the micro level, so on the individual healthcare workers. I think up to now, and you can share your ideas when we get there shortly, most of the focus has really been on the micro level, and we also need to look at more macro meso level. A whole community approach can close the public health policy gap because it helps us recognize the broader determinants of population mental health. And it looks at public health interventions more systematically across systems. And it can help us to bring together these different initiatives in a more strategic way rather than in silos and isolations. I'm looking forward to hearing from you on your thoughts on that. But let's look at some of these micro, meso, and macro level factors. Next slide, please. So in terms of micro level factors, most of the focus addressing trauma remains at the individual level. Despite the increasing recognition of the widespread nature of trauma as a population level epidemic, particularly in a pandemic like this, mostly trauma is dealt with and considered at the individual level. Using a trauma-informed approach that recognizes the pervasive impacts of the pandemic and the new exacerbated mental health challenges facing healthcare service providers and the patients they're treating will help us rethink our efforts. A trauma-informed approach may or may not require disclosure of trauma. For those of you who work in the trauma field, you know this. Services are provided using an approach that recognizes the need for physical and emotional safety, as well as the individual choices and control in the treatment decisions, and importantly, in our efforts not to traumatize or re-traumatize folks. Next slide, please. In terms of the meso-level factors, creating positive practice environments, healthcare settings can support decent working conditions, attract and retain staff, provide quality patient care, and strive for excellence and strengthen the health sector as a whole. And this is from the World Health Professionals Alliance recommendations. Providing protections at work. We remember how early on this was a key issue when PPEs were not sufficiently available. Enforcing safety regulations related to infectious disease and mental health support. And also collecting relevant and accurate data to understand the inequities in workplace and how these inequities influence health and well-being is important. We hear about it in the media, but we need to collect data in order to plan, but also to advocate. Next slide, please. So in terms of the macro level, the bottom part of that pyramid that I had on a slide a few slides ago, incorporating health equity into pandemic preparedness phase, as well as response and recovery phase, and also adapting our mental health system to meet urgent needs. So there might be a pandemic of mental health needs. How do our mental health systems address this? Making sure to provide emergency core and flexible funding for mental health care, which compared to other sectors of the health field continues to be underfunded. Countering misinformation and disinformation in terms of COVID's transmission, fatality, and as you're hearing more and more these days, vaccine. Eliminating stigma and discrimination and violence in health system towards healthcare staff and patient, and even the communities that they live in. And engaging in post-pandemic recovery and preparation for future waves, for changing waves, for the changing context, in relation to supporting the mental health of the human services sector. And just to remind you, today our focus was on healthcare providers, but by no means does this cover the entire range of human services sector. And next slide, please. So the third question that we'd like to share with you and actually learn from you is, what are some of the policies and practices that you know of that support and promote mental health of service providers during the pandemic? And next slide, please. This is our contact information, which will be on the PowerPoint that's posted at some point. The recording is posted on the KMB website. So our email, our website, our Twitter handles, and just acknowledging some of our colleagues at the office, including Dr. Luz Maria Vasquez. And we're just acknowledging the images that we used for our slides are from Microsoft Office PowerPoint. And final slide has some of additional references, but also we've provided the references on each slide. Michael, we are done with the presentation part, and I see that we do have some time. Please let us know what we should do at this point.
Fabulous. Well, thank you both very much. I have a couple questions that are queued in the Q&A box. I will share them in order. If there are others from our participants today, I invite you to add them. The first one came in from Jennifer. How does regional government fit into supporting frontline workers, particularly long-term care and public health staff? Do you think they could play a role, or would the Canadian-wide public system be the preferred structure in your opinion?
So if we apply, Jennifer, that, and I'm sorry I can't see you, right? Is that correct, Michael? It's just us. It's just us who speak into Zoom, right? We can't see the participants. Is that correct?
At this time, yeah. What we might be able to do now is.
All right. So Jennifer, thank you for the question, and thank you for attending today. So if we apply really a whole community approach, the regional is very important, but none of these governments, work in isolation, and that's why the working at the neighborhood community level is a part of the solution. But how do we also reach out to larger levels of government in terms of policies and practices and financial support of specific sectors, as well as how does that then come to the micro level? How does it directly support frontline workers in terms of job protection, benefits, and mental health services assistance? So regional plays an important part, but it's not in isolation from both the larger provincial, federal policies that are COVID specific right now. And then it should specifically contribute to the workplace settings of the frontline workers who are in need of those supports. If you have additions to that, Jennifer, in relation to what I just said, please share your perspectives as well.
Thank you very much. I'll move on to the next question on the list. This came from Michelle. How can families support their loved ones that work directly with COVID-19 or potentially be in direct contact? There is a fear of disclosure of occupation due to stigma. You may infect the person.
Yeah, and you know that is a question that I wish in a way so I could see your faces and we could engage in a back and forth dialogue. But I can say that, my husband's a frontline worker, and we had to support, we had to think of ways where he was worried about bringing the infection home. And I'm just sharing you, I don't have an answer for everyone, but I'm just sharing with you how we dealt with it in terms of just earlier on setting up a structure in terms of his fear about bringing the infection home. So where he took his clothes off just before he came home. And as soon as he came home, he would go and, take a shower right away. and providing the opportunity, again, just this is how we've dealt with it. I'm not sure how it's going to impact everyone, but providing the opportunity for him to talk about it if he wished, and for him not to talk about it if he didn't want to. And occasionally I would ask him about how his day was. So I don't have an answer for everyone, but I found that with regards to us, just setting up a structure for, and he, you know, he did this himself, where he makes a bit of a transition from coming from the work environment, just a transition once he gets home, and then he comes and inserts into the family home environment, has worked for us. Again, please, if others have suggestions, ideas, please share in the chat box. Michael, at this point, I'd be curious if you can just share some of the responses in the chat box before you go on to other questions. Any suggestions, any ideas throughout the presentation on any of the questions that we've raised?
Some of the conversation in the chat boxes has moved over to the questions. There are a few more questions. It was a really interesting comment from, I mean, I use the chat function as a stream of consciousness. So for folks that got distracted, I apologize for that. But Pam had a really good comment in chat earlier about that sense of health workers as superheroes, and some of the stress that causes around, oh, you're so strong, you're so courageous, and in some cases that creates a bit of a stereotype that causes strain in itself. So I found that really interesting. But I'll read the next question out from Samson. Is there any?
Just to add on to that,
sure.
The notion of superheroes, or I think I was presenting or listening to Attia, so to tell you the truth, I wasn't reading the chat box very closely. But I think there was also something about resilience that someone mentioned. And, you know, the notion of resilience, often people think about it and it gets used as an individual level, but we need to more and more talk about resilience of healthcare settings and healthcare systems, and resilience of communities. And especially in a pandemic like this, where we're all interconnected with each other because of infection or barriers to infection, we can't look at it just in terms of one particular person being resilient to deal with the pandemic, whether they're health professionals or other frontline providers, or they are partners of folks from the frontline sector. So we need to, and there are ways to look at resilience beyond individuals. So individual resilience, there's a lot of literature on that, but also resilience is looked at more from a community perspective, a society perspective. Perhaps we need to start talking about resilience of healthcare systems vis-a-vis when we are undergoing a pandemic, and different components of that, supporting patients and clients and their families, but also supporting staff who work in those systems is important. Sorry, Michael, I cut you off.
No, all good, all good.
Can I add something on that as well?
Sure.
Yeah, so I also feel that, you know, resilience also comes particularly from peers and colleagues as well. So a lot of those healthcare workers are working in teams, and so those teams, I can see that they support each other. They're in together, because when they're managing patients, when they're managing the flow of patients, the increased work environment, if they weren't cooperating with each other, they weren't helping each other, then this system or everything would, it wouldn't work out. So we can see that resilience also coming in from each other, from their community, the healthcare community itself. Yes.
Thank you, Attia.
Thanks. The next question comes from Samson. Is there any mental health support consideration for refugees working in the front line as PSW or RSA or even cleaners, etc.?
Yeah, and Attia, you addressed some of the issues in terms of precarious work and immigrants. So we were very, initially when we did our slides, we had an intersectionality lens, but because of just time just respecting time, we took that lens away, but we still hopefully underscore the importance of gender, migration, racialized status. I'm not sure, Attia, if when you were working on looking at what programs are available, whether you came across any specific supports for folks who are refugees or have precarious status in the healthcare field.
Yes, so around precarious status, because like Nazilla mentioned, so there's a group of people who are the economic healthcare providers, specifically like who are providing the care in people's homes. So that is one group that there was a lot of there was some reports about them, and the people. Those are that group of people who really need to be supported, especially around income and being provided sick leave, or have and make sure, because a lot of them were also fearing that they would lose their jobs. So we need to give them that kind of a protection, and I think that kind of a protection also helps them with their mental health, because being insecure when you have to worry about food, you have to worry about a home, and on top of that, having the a higher risk of getting COVID-19, so that I think that all adds up. That's a lot for some people, and then when you're not even sure, where you stand, or, regarding your employment and other supports, like for example, they may not have access to mental health, psychotherapy and all the private healthcare that they can access if they don't have that insurance.
Yeah, and so what actually the pandemic does is it exacerbates the social determinants inequities for folks who may not have regular employment that has some benefits, who may who may have access barriers because they don't have the recognized refugee status, or they have precarious immigration status. So the inequities and the risks are exacerbated both because of those migration status factors, but as well as that being expanded and amplified with the pandemic specific challenges that the folks face.
Thank you very much. There are a few more questions. I will go back to let everybody know it's possible we won't get through them all. I want to be respectful of time, but we'll jump right into the next one. This one from Michelle. What are your thoughts on universal pharmacare and universal mental health care?
Michelle, I can talk about universal mental health care, and I know with pharmacare, just in the last few days, it's been on the media. So my perspective is that we need a public mental health system. And when in Canada, the way our healthcare system is set up, when it is public, then there are a range of services that are covered by our provincial health coverage, if you will. So if you're an OHIP and you need access more at the prevention and even at the promotion end of mental health services, those are available through our provincial government funded. Right now, it's very, it's tough if you don't have a full-time position with benefits to support individual focused mental health therapies or supports. And so unfortunately, most of the access to mental health care ends up being at the more tertiary end, when folks are really in a crisis. And so they may show up in emergency departments in order to get some tertiary mental health care. But I think if we're being more strategic, just like with other sectors of health, and more preventive and promotive, we can apply the public mental health lens and have more equitable funding where people don't get to that crisis point before getting any mental health care. So some of the therapies right now that are often the more prevention, psychotherapy and individual therapies are dependent on the types of benefits you have, if you have any. So my personal opinion, and I'll talk about mental health because that's an area I know more about, is that, this is a very opportune time in Canada, in Ontario, I presume in other provinces too, for us to engage and advocate for a public mental health system, for public mental health. And it's opportune because unfortunately we are seeing the concerns around mental health experienced by all, including frontline workers, not going away. As a matter of fact, in some, they are becoming more critical. Thank you, Michelle, for that question.
Thank you. The next question is from Spencer. This is a really unique one. York University is not alone in its commitment to experiential education. Other universities are really engaging in this as well. Spencer's question: how do you think the pandemic will affect the ability for those in school to gain experience or practice in various healthcare facilities, whether it's police, nurse, social services, home care, etc.?
So Spencer, thank you very much for that question. And I think I am going to leave that question for colleagues who teach clinical or applied courses, and they would be in a better position to be able to respond to that important question.
Thank you very much. I'll move on to the next one. There are a couple more on the list here. There's another one in from Jennifer. Do you think that immigrant and BIPOC frontline workers are further disadvantaged by the mental health system due to systemic racism, such as different language advertising, healthcare, and referral discrimination? Do you think equity and anti-discrimination requirements should be built into mental health and pandemic response policy? What do you think these requirements would look like?
Excellent question. Attia, do you have any thoughts on that? And I know your PhD in a way addressed aspects of that, but that's an excellent question, Jennifer. Do you have any thoughts on that, Attia?
Yes, I can add to that. So yeah, we have seen time and time over again and again in published research, and we've heard it from the different research projects that I and Nazilla have been undertaking. We've heard from people, from Black mothers who are racialized communities, what their experiences are, what they have felt, and what they would like to see. So time and time again, and there have been a lot of people who've been speaking out about this, right? So so racism and discrimination, as we can see, it's at both ends as well, right? So it's also from the patients, and we can also see the healthcare staff experiencing the same thing. So people who are using the mental health service, they feel the same thing, like if they are, they have a different a behavior, specifically, like I heard from youth, and that they felt that healthcare providers weren't able to understand them, right? They weren't able to connect to them. They weren't able to see things the way they experience or understand their experiences. But at the same time, we can see the same thing at the healthcare forces. So if you look at the medical profession, that's also where, if you can see it, there's a lot of gender. Women, they experience a lot of, in a way, I'd say, I wouldn't call it discrimination, but there are different levels of experiences if you are a woman, if you are a colored person, even in the healthcare sector. So the way to improve on that is, again, like if you were to take a whole community approach. So we need to look at, building that, making people aware of that at the individual level, at the community level, and even at the policy level. We need to work on that and build on eliminating, or at least reducing as much as possible, the discrimination, the stigma. I think even the stigma as well around mental health care.
Yeah, and I want to just pick up on that, Attia, and I see, Michael, that we're heading towards the end. Maybe just a concluding a couple of points just on what Attia mentioned and these great questions. I'm sorry we couldn't get to all of them, but I think, you know, coming together and talking about mental health as you've joined us today is a first step in taking the stigma away. It is so important for us to continue to talk about mental health. Having said that, I know that sometimes talking about mental health and health issues in the work sector can be a risk. So how can we, again, just applying that upstream approach, make it less risky for employees across sectors, including the mental health care field, to reach out for help, to talk about health issues, and in particular mental health issues, which is a very, continues to be a stigmatized area, without feeling like they are going to put their employment at a risk, put their types of shifts they get at a risk, put their types of clients that they get assigned to, perceived by their peers at a risk. So how can we, in addition to talking about mental health issues, advocate and think about work structures, policies, where folks who need, who reach out preventatively to seek out mental health care and services, assuming that they're there, don't feel that they're putting their position at a risk, their respect by colleagues at a risk, and their promotion at a risk through the structures of the various healthcare systems that frontline workers work in. On that note, Michael, I think we are heading toward the end. I want to thank you and Krista again, Michael, for providing this opportunity. I also encourage you to all of us just to continue to talk about and see how we can advocate in the various hats that we wear. For, I would say, a public mental health system. You know, that really is my vision for Canada, that one day we will have a public mental health system. Yeah, I think I don't have too much more to say, Attia. Do you have any concluding thoughts? Or Michael, do you have any concluding thoughts?
Yes, I support that. I support a public mental health system. So we've been hearing that, we've been, over and over again, that we need to have a public mental health system. And what's missing, we need to provide that, the psychotherapies before we go for the medication. And that's what I really support and promote. And I think we need to do that, reach out to those people before they need to go on medication. We can help them. And that should be available, rather than having, a person have a full-time employment. Why isn't it available for everybody? Yes.
Well, I just want to thank everybody on behalf of Krista and myself, to Dr. Khanlou and Dr. Kahn. Thank you both for your time and insight and just so freely sharing of your research, your experiences, but also posing questions. So this is an extremely complex and important topic. To our participants who made the time to join us today, thank you so much. We will be posting today's webinar on the Knowledge Mobilization website, probably within about a week or so. And to those who are supporting some of the most important work within our communities, thank you all. Stay safe, keep well, and take care. Enjoy the rest of your day, everybody. Thank you.
Thank you.
Bye.
Thank you.
Bye.